Good morning, everyone. My name is Gillian Saunders, and I am the Director of Healthcare Compliance at Housing Works. I just want to take a moment to thank CHCANYS for letting us present today and for being here with all of you. It really became a very meaningful exercise for us to sit down as a group and kind of review the past 2 years and how we pivoted in response to the onset of the pandemic, how we adjusted and grew over the past 2 years, and kind of where we are now and how we're looking to the future. So we did do something a little bit different. We did a little voiceover on our slides so that more than I could just participate, but I promise you will hear my voice again. So I'm just going to go forward with them, and I hope you enjoy it. Thank you again.
Hi, everyone. My name is Pat Troy. I'm the Senior Vice President for Healthcare at Housing Works, and I want to thank CHCANYS for this opportunity to explore with you what was Housing Works' response to the COVID-19 pandemic. It was a very interesting exercise for our agency to do this because it reminded us of all that we had accomplished over the past 2.5 years, especially as New Yorkers responding not only to our staff, our patients, but also to the community at large. I think we would all admit that emergency preparedness is not the sexiest thing that we do as an FQHC, but I have to tell you that I believe that the structure that this gives us, as well as the exercises that we have done over the past couple of years with CHCANYS and other state agencies, really prepared us for, as best we could be prepared, for responding to this pandemic. We immediately stood up the incident command team. We started communication channels using the Emergency Preparedness Committee. We established our Chief Medical Officer, Dr. Vati Poitvian, as subject matter expert, especially since this was a medical emergency. And she was the filter for all information and clarifying misinformation. We reviewed the diversity of the agency because we, as you know, Housing Works has housing, we have healthcare, we have the thrift stores. We are, very different in all of the aspects of the agency. And what we did is we made sure everyone on the executive team who represented those different divisions was together every day. We had daily executive team meetings, and we were transparent in our communication across the agency. We provided training as needed for PPE, COVID safety, testing, vaccines, etc., and we continued clear communication to all staff, and we really continued to reorganize our communication channels as needed. This was just not one-way communication, right? We did not just dispense what the executive team or the incident command team wanted to tell. What we did is we spent a lot of time listening to the needs of our staff and our community. So this is a brief outline or timeline of the things that we, Housing Works, achieved during this time. So in late March 2020, we started a pop-up testing at our downtown Brooklyn clinic location. In July 1st of the same year, we took over operations of our first DHS hotel from Callan Lord. We were in Long Island City, and we were operating just not only the hotel, but providing medical services, both primary care, psych, and therapy, to those clients who either tested positive while they were in the shelter system or were exposed to folks who tested positive. In the next month, we began operating the medical and operational components of 3 Mach J hotels. We partnered with Exodus, who was doing the operations of the hotel, and we were providing medical and behavioral health services. Mayor's Office of Criminal Justice was the sponsor of these, and we were treating residents who were recently released from jail or prison. In December of that year, we had our first COVID vaccine administered at Housing Works. It was Moderna at our clinics. And then in March, we began administering J&J vaccines at our HRA sites. One of our programs took on a large testing and ultimately vaccination contract, going to all HRA sites and working with the residents who live there. In August of 2021, we transitioned from the J&J vaccine to Pfizer at the HRA sites, and now total we have administered 977 doses of J&J, 3,216 doses of Pfizer at the HRA sites, and we have also administered a little over 5,000 doses of Moderna at our clinics. So this is just a fun collage that we put together that really the staff used as a communication tool. Many of the pictures are staff and leadership staff on the left-hand side. And then on the right, what we had was a Christmas tree where ornaments were actually COVID-themed ornaments. And the funniest thing is that our clients wanted to know where we got them because they loved them all so much. So there's nothing like a pandemic, an emergency, to make you do those things quickly that you've been waiting for that perfect time to implement. So Housing Works have been talking about doing a lot of telemedicine for quite some time, and we hadn't. So we accelerated our adoption of telemedicine out of necessity, and we went from 0% telemedicine to 62% of our visits the week of April 17th, 2020. And they included all of our disciplines: primary care, psych, and psychotherapy. One of the great things that happened, especially at the beginning and continues even to this day, is the partnership with our other programs, our other departments. So with the thrips closed down at the beginning of the pandemic and community partnership, our business growth program really couldn't go outside for staff safety reasons and bring business in. They came into the centers and they worked directly with our clients to have them register for virtual visits. And they enabled them on the ECW Helo app, and they walk patients through their televisits. They would help them connect and then really assist them to be able to do this at home. We utilize multiple telehealth platforms: Doximity, Helo, Zoom, and Microsoft Teams to engage the clients. Our ADHC, our Adult Day Healthcare Program, engaged patients by conducting virtual group visits and established safety measures to distribute meals 2 or 3 times a week. We partnered with T-Mobile to provide prepaid smartphones to clients who needed these to engage in care. And even now, our televisits range from about 30 to 33% of our total visits, most of these being in our psych and our psychotherapy. Housing Works partnered with other volunteer agencies to collect and distribute PPE to hospital and frontline workers. During this time, we really did a great job of touching 1.5 million people. We distributed 16 million items of PPE, 13 million masks. We had events at 60 hospitals, again, that we co-sponsored with other agencies. We distributed over 20,000 gallons of hand sanitizer, and we also had 20 events in public housing. We also continued other ways and kind of moved to figure out what we could do even in our thrift shops. And what we were able to do is we were able to collect and donate HIV medication through a medication recycling program at our Housing Works Gramercy thrift store. During that time, the first year, we were able to really donate $44,515 worth of HIV medication. So I'd like to go back to our HRA program where we went to safe havens and other housing units that were sponsored by HRA and talk a little bit about how it started with testing. Our total testing during this COVID-19 pandemic through our HRA program, we performed over 16,000 tests. We started with the HRA sites. We also worked at the Department of Youth and Community Development, and we also went to 30 sites for the Administration of Children's Services, ACS. The sites are for HRA were located through 5 boroughs and really consisted of a variety of transitional housing, congregate housing, domestic violence shelters, crisis shelters, residential locations, you name it, and we were there. I mentioned 2 parts of our hotel response. And again, in the DHS hotels, we operated the hotels as well as provided medical and behavioral health services. The DHS hotel experiment, let's say, kind of grew and shrank as the pandemic went through its spurts of incredible contagion and then receding from that. We currently operate 2 DHS hotels, one on west side of Midtown, and again, the original one in Long Island City. To date, we have provided 1,300 primary care visits, 5,200 COVID-19 visits, over 2,000 behavioral health visits, almost 300 psych visits, and we have actually touched 6,631 unique individuals, with 1,400 of those being uninsured. During this time, we have hired approximately 65 staff members, and we had to do that almost overnight each time we opened up another hotel. And the other part of our hotel response was the Mayor's Office for Criminal Justice. So we grew that slowly. Well, I guess maybe not slowly, if 2 years is the time span. We now operate 6 mock J hotels. And as I mentioned, these are to receive people who actually are released from jail and prison, acknowledge that they have no place to go, that they were originally residents of New York City, and would really be homeless or entering the Department of Homeless Services system if this mock J hotel system had not been set up. Exodus is our partner. They operate the hotels, and we provide primary care and behavioral health. In this group of hotels, we have provided over 3,000 primary care visits, 800 COVID-19 visits, 3,100 behavioral health visits, and over 1,200 psych visits. We have provided care to 1,800 unique patients, and 100 of those, a little over 100 of those patients are uninsured. Each hotel is staffed with an RN, EMTs, and primary care, social worker, CASEX from Exodus, and harm reduction specialist. We also have psych providers who are there part-time, and they kind of round out our staffing. And at this time, what I'm going to do for the rest of the presentation is hand this over to Gillian Saunders, who is Housing Works Compliance Officer.
Hello, everyone. My name is Gillian Saunders. I'm the Director of Healthcare Compliance for Housing Works, and I'm also the Emergency Preparedness Lead. So what are some of the things we've learned over the past 2 years? Well, first of all, we confirmed that even more so in this unprecedented time, we can stand on the 3 tenets of our mission statement, and those are empowerment, innovation, and collaboration. We use these very much so over the past 2 years. In talking about our lessons learned, we narrowed them down to 4 areas, and those are communication is key, staff safety and wellness, client and community care, and impact on the workforce. So let's talk about the first one. Communication is key. So very early on in the pandemic, we activated our incident command and set up an extensive communication structure that was designed to involve every level of the organization, from the C-suite to the front line. And this involved establishing our CMO as the subject matter expert. She was essential in filtering information and clarifying misinformation. Having leadership calls at 8:30 a.m. every day. I can't tell you how much we loved that. To discuss staffing and other issues of the day. Staff huddle, which involved the entire healthcare staff, was used to disperse COVID-19 information and update protocols. And we sectioned those out to Clinical Mondays, Wellness Wednesdays, and Technical Fridays. Clinical and operational leadership meetings every afternoon at 3 p.m. We discussed clinic challenges and action plans. And of course, the executive team met daily to discuss agency changes and disperse information through what we called a virtual agency update. So the key being to have communication and transparency in decisions and policies being updated, and as a secondary source of information to back everything up on the intranet for easy access. Next up is staff safety and wellness. And our view is to always err on the side of safety. Before even New York, we implemented mask mandate for our staff, clients, and visitors. We believe always more and never less when it comes to PPE. And during this time, we accommodated working from home remotely using over 1,200 phones and MiFis and 725 laptops. As far as wellness goes, we also realized that our staff was impacted mentally, emotionally, physically, and socially. So we established something that we've come to know and love as Wellness Wednesday, where the behavioral health leadership and other guest speakers talk about all of these issues. HR kept the staff moving, giving us access to free class pass, and additional PTO allowances were given for time to go and get vaccinated, tested, and unfortunately, those COVID sick days. We created community forums for open conversation, and we provided grief counseling for any staff in need. Engaging clients in the community was essential at this time. So some of the things we did was to partner with our community-based organizations, providing them with appointments for vaccinations and ensuring that their staff was safe, their clients were safe, and they were able to deliver their much-needed services. We signed up with a really innovative service called Dr. B, and this connected users to leftover COVID vaccines in their area, so that extra dose of vaccine that we squeezed out of the bottle went into an arm. We went door to door to our neighboring businesses and made sure all of those essential workers received their vaccines. We opened testing to everyone, including staff, clients, partners, and the community. We utilized multiple telehealth platforms such as Doximity, Helo, Zoom, and Teams to engage our clients. And very importantly, we stayed open because we understood that portions of the community were unable to engage in telemedicine. Impact on the workforce. So as Pat mentioned earlier, we expanded our portfolio to include hotel contracts during this time, but we came to realize that payout from contracts can take up to 90 days, having a real effect on cash flow. Staffing became a bit of a revolving door with a lot of turnover from fear of working in healthcare. Increasing demand for healthcare staff then led to increased salary demands. And through the first year of COVID, our visits were off by 13% in the first revenue number. We also found out that vaccines are, guess what? pretty costly. And the COVID response funding that we got were used to expand testing and vaccines, but had very little impact in terms of relief for our revenue loss. So even though we temporarily closed our smallest clinic, we are proud that overall, during this time, we were able to expand. So what are some remaining challenges? Staff turnover continues as fear of working in healthcare continues. We will continue to see loss of revenue and look to the federal government for support for funding. Exhaustion and reinvigoration of the public health workforce, and looking at segments of the population that will continue to need in-person health care, and the effects of the expansion of telemedicine on how we engage the population. Lastly, we have to thank our partners, including CHCANYS and HRSA, for providing much needed PPE for staff and for all of our safety. The federal, state, and city agencies who were very responsive to our requests and needs, and for providing adequate testing and vaccine supplies. So thank you for giving us the opportunity to share our experiences with you today. Please feel free to reach out to either one of us with questions or comments. You can reach us at the emails below.
Thank you.
Good morning, everyone. Thank you, CHCANYS, for having us here today, and to Samantha for framing the human response to trauma. Today, we're going to share our health center's response to continue to provide quality services during the peak of the pandemic. My name is Anna Otero. I am the director of the FQHC's health services at VIP Community Services.
Good morning. My name is Raquel Rodriguez. I am the risk management specialist for VIP.
A little bit about us. As of April 1st, we are 48 years old and have been serving the East Tremont section of the Bronx. Father Robert Bonomi witnessed the socioeconomic barriers to health addiction ravaging the community and established VIP as a safety net. Since then, VIP has expanded its services to meet the needs of our community members. Our main site offers a 24-hour access center, primary care services from crib to golden years, GYN, ophthalmology, preventative medicine, chronic disease management, behavioral and mental health services, addiction recovery services, inclusive of medication-assisted therapies, vocational education services, and case management. We operate two residences, 10 supportive housing and shelters with locations in Brooklyn, Queens, and the Bronx. Like many of you here today, we are a patient-centered medical home. Additionally, we are an accredited rehabilitation facility and a certified community behavioral health center. In 2020, we broadened patient access to services by implementing telehealth services. I will now turn it over to my colleague, Raquel.
Thank you, Anna. So I'll begin by providing a brief overview of VIP's emergency preparedness infrastructure. And I will highlight our key points of processes implemented in response to the COVID-19 pandemic. So we began by activating our incident command system. Our COO serves as the primary incident commander. Additionally, we developed a COVID-19 task force that included clinical and non-clinical staff. We met on a weekly basis, and we continue to meet monthly as needed as the COVID updates continue to change and regulatory mandates and recommendations are issued. And from previous lessons learned, we learned how important it was to have access to mass communication capability. For initial situational awareness, our incident commander utilized our regroup mass communication software to send out our message to the task force team when the pandemic was declared. Thereafter, our public information officer / HR lead developed our News Corner emails, sending messages to staff every other day and on a weekly basis, and continuing to do that to this day. So the lesson learned here was to have multiple channels of communication for effective and timely notification to staff in our community. Further, we are enforcing OSHA recommendations, making sure we're OSHA ready and compliant with protocols and guidelines, and in so intensifying infection control strategies, increasing telehealth services, decreasing number of staff on site, the installation of safety barriers in offices, and especially in shared spaces and client-facing areas. Now, our lesson learned here too, when it came to PPE, as I know, we were all faced with several challenges, is sourcing and maintaining a 3-month stockpile of PPE, no thanks to donations from the community, from NGOs and vendors. During difficult times of supply shortage and delays in supplies, we relied heavily on our longstanding relationships with our vendors. Anna will present our community outreach services.
Thank you. With our outreach tactics in place and running like a well-oiled machine, we could focus on vaccinating our communities. Since the spring of last year, as you can see here from the photos, we have vaccinated community members that are homebound and attended Pee Wee baseball games, as many health fairs in collaboration with our stakeholders, including City Council and our Bronx Borough President. We have been blessed with our community's trust in us. The notes of appreciation are comforting, especially on days where we are expected to vaccinate at 2 separate events, miles away from each other with limited staffing. We have been fortunate to have our CEO, Debbie-Ann Fletcher-Blake, and our Chief Clinical Officer, Darcia Bryden-Curry, on the front lines providing vaccines alongside our nursing staff. VIP remained open during the pandemic. We switched over to a hybrid model of care where we provided services on site and pivoted to using telehealth by offering our patients virtual and telephonic treatment options. Some patients were very happy that they did not have to come into the clinic to meet with their PCP. They could expect to receive a phone call for services needed. We are fortunate to have Azara Drive's pre-visit planning tool where we could inform patients in advance not to come into the clinic when we had bad weather. Staff were extremely happy to be able to work from home when needed. Texting patients to get them vaccinated has taught us to use this same tactic for other care gaps. With Azara's healthcare patient outreach model, we have scheduled routine text blasts to our patients that are either due or missing screenings, annual wellness visits, or other vaccines. We recently expanded to include the seasonal flu vaccine as well. The patient outreach package generates lists based on the status of the text blast. This helps my team to inform the care team's PDSAs on how to improve response rate, and more importantly, if the text leads to an action being taken by the patient. On behalf of my colleague and I, we want to thank CHCANYS for inviting us to present VIP. Thank you.
Good morning, everyone. For those of you who don't know me, my name is Chris Quinones. I'm the Chief Administrative Officer for Sun River Health. Sun River is a federally qualified health center. We have health centers, 43 health centers in all of New York State. We range all the way from the top of the Hudson Valley, come all the way down, all 5 boroughs of New York City, and we go all the way out to Suffolk County, Long Island. For those who do not know, the Sun River Health was formerly 2 organizations, one called Bright Point Health here in the city, and the other one called Hudson River Healthcare. And so we merged about 3 years ago. And the importance of that is that when you do your calculation, we merged 3 years ago. We had a pandemic start 2 years ago, two plus years ago. And so as you can well imagine, a lot of lessons learned and a lot of need to collaborate and bring 2 different groups together very quickly. We had done tremendous amount of transitional work, of course, but the pandemic really kind of caused us to flex muscles, flex infrastructure to see how we were going to properly respond. The other thing that is really important to kind of point out before I go through my slides is that The person that stands before you is actually a graduate of one of the most prestigious universities of emergency management, and that is CHCANYS in partnership with the Department of Health. It has come full circle because I also was in this audience when CHCANYS first started this venture, and everything we have learned from emergency management was at the helm through the technical assistance of CHCANYS. So I'm not sure you might want to use that as an ad somewhere. So with that said, told you a little bit about Sun River, but we really kind of want to get into the meat of it, right? So we realized when we were preparing for this presentation that that we went through a number of phases during the respective pandemic. And I'm going to walk you through those phases and some of we call them best practices, but really for us, they're just practices that we think will repeat until we learn something better, okay? So the first one, phase one, was the initial awareness and high alert. So as you can well imagine, taking it to the beginning of the pandemic, we all faced that, right? It was the initial awareness, what is going on? What is happening, and how does that affect us as individuals, and how does that affect us as an organization? So what we realized is that our key change in the beginning awareness part was to be careful. So we needed to establish some quick protocols to limit risk. All the same protocols that you all were following, we were following, i.e. the separation, the introduction of PPE more frequently and in places where we weren't utilizing it before, i.e. the front desk and things of that nature. But really what was really a key component to it as well was the messaging. What was our messaging to our staff? What was our messaging to the community? And our message was that we're still here to serve. And we know that we were in a time of fright, of panic for many, but we had individuals, we had actual messaging from the outside, signage that said, we're open, we're here, ask us questions, etc. And we wanted to make sure that we remained a resource to the community because that's what we all do. Then things got a little bit more complicated, right? So we ended up going to the next phase, what we call separation. So here, this is when we started seeing record levels of infection rate. This is when we were seeing record levels of hospitalizations, and we needed to take further action, as I'm sure so many of you also did. So in our case, what we did is we started to implement new schedules for sick visits and schedules for well visits. And what we started to do was separate that. And so a lot of times when we think about separation, we think about two different rooms, two different wings. No. We separated the day. So we purposely set up for all of our well visits to be in the morning. Think about it. The night before, you went through an entire deep cleaning process. Everything has been disinfected. And so you bring in your well visits in the morning when everything is what it's supposed to be, status quo, disinfected, safe, etc. And what were well visits? They were concentrated on high priority cases, pregnancy, pediatrics, for immunizations, etc. So they would all be seen in the morning. And then in the afternoon, we would bring in what we'd call the sick visits, okay? So there was a lot of screening, a lot of education of our call center, who was making these appointments, and also of our reception desk to ensure that they screened and they properly scheduled people so that we would have the physical separation and the time separation of the two populations, in essence. And then we also separated service lines. So this was at the point where, through CDC recommendations, we stopped doing the dental work. We started to pay attention to areas that weren't as high priority and start shifting those patients to telehealth, of course, so that we start reducing the amount of people who were coming in to the respective health center. And again, when I talk about 43 health centers, I failed to mention, we're seeing over 245,000 patients. Do your calculation in terms of the amount of visits, our waiting rooms stay pretty packed. So that's why we needed to do this, because we could not have a packed waiting room. Now, the next phase, and again, it just kept on getting more complicated, and so we had to keep on flexing. We have to keep on adjusting. And so we actually needed to go to a phase called reducing exposure. So here is when we really made a concerted effort to reduce the on-site care. This is when we really tried to maximize telehealth. And I will tell you that when we talk about adapting to a situation, we went as far as taking, because I did not mention this, we operate 4 mobile health units. We took one of those health units and completely retrofitted it just to be a telehealth pod. We would send it out to certain communities, certain shelters here in the city, where individuals, we didn't want you traveling, right? Everyone was staying away from traveling, et cetera, staying home, but you still needed care. So we would send the unit out to you. And that gave people an opportunity to get on the unit. It was right in front of their door, and they would be able to interact with their provider. That also helped to alleviate some of the connectivity issues all of our patients were suffering, because as we all know, in some of the areas our patients live in, there's not enough investment in terms of the IT infrastructure needed in those areas. So we did that. Then it got even more complicated, as I say. We had to go into what we call a reallocation and a regionalization phase. Regionalization was plain and simple. We started reaching a point where we couldn't staff all of the health centers. As so many of you suffered, we did as well. And what that meant is what we saw as a fear from the outside happening in the community was starting to be realized as a fear on the inside, because all of our staff were becoming infected. Our staff were not showing up to work. So what we had to do in certain cases is close certain health centers and shift staffing into a centralized health center, and then communicate to that community, we're still open, but we're open over here, and then implement transportation services, because we do run a tremendous fleet of vans to take our patients to our health centers, but also we were using Uber Health as well, getting people into the health center in that way, especially when it's not their local health center. Now, from going a couple of blocks away, they had to travel 1 mile, 2 miles, 3 miles, 6 miles to one of our nearest health centers to receive that same care. But we didn't have a choice. We had to kind of redeploy our staff because we had staffing shortages based on them getting sick. Then, finally, we start to breathe, and we go into the phase called reemergence. This is where we have folks starting to return back in care. Our staff have recovered from COVID. They're coming back, et cetera. And then, but we still notice we have shortages. So in that phase, we started doing some cross-coveraging. This is where you start taking individuals who are in different positions, assessing their skill set, and shifting them to do other roles. Perfect example, we will take a patient navigator who may navigate them through our system, because as you all can well imagine, as federally qualified health centers, we have grown tremendously and have a tremendous amount of services, and our systems can be a little complicated or complex. And so these navigators would help people navigate internally, where to go, what's the resource you need, et cetera. All of a sudden, now we had to redeploy them to be chronic care managers, because during this pandemic, we still had individuals who were really, really sick, as we all do. And so we needed to follow up with their care. So that was a perfect example of the redeployment. And then finally, we got into where we're at now, which is what we call the stretch phase. Stretch phase was ongoing redeployment to address any COVID absences that we might have, and the hiring challenges, which I know I saw a speaker coming up today that's going to be talking about the hiring challenges and or the recruitment challenges that we all are facing. So I won't go into a deep dive on that. This that you have in front of you is actually what we call the dashboard that we started to do on a daily basis to manage not only just the reemergence, but really the separation phase. In about 4 or 5 phases, we had to utilize this dashboard. And this dashboard was a daily assessment of where we were at in terms of staffing. I failed to mention, one of my colleagues earlier did mention the concept of communicating. All of this that I'm mentioning actually took place by way of, yes, our incident command structure. Our incident command structure, as our organization, a lot of people on it, fairly sized, multidisciplinary, et cetera. And what we ended up doing was we were having 2 calls or Zoom meetings a day. We had In the evening, at 6 o'clock every evening, we had a Zoom, it was called a strategy session. To me, or in EM terms, it was probably called a hot wash, but we called it a strategy session. And then at 7 in the morning, we had what we all like to call a morning huddle, but we just had a larger morning huddle. And in that call, we had all of us as chiefs, so the entire executive team, senior management, frontline management, okay? So we had over 60 plus individuals on this call twice a day. In there, it was served as great ability for us to learn from one another, hear and process the information that we are getting so that it's not being done in a silo. Think about it. Every single hour, 2 hours, 3 hours, 5 hours, and definitely daily, we were getting new notifications from the CDC. It's funny how I can sit here today and say, do you remember that? But this is what we were all going through. But it was really important that we all processed and dissected that information together so that we understood what was going to be the new practice. We were all communicated to at the same time. And then, of course, we utilized text messaging platforms and everything else to disseminate the information. But most importantly, there wasn't a single manager or director or chief or vice president that did not get the information directly. We all got it at the same time. We all discussed it, and it made it cohesive enough so that now when that vice president, that director, that manager goes back to their staff, we are sending the same clear, crystal clear message, which is important. Communication, communication, communication. And then in the morning, we look at this together. Where are we today? How many people called out? So these were the phases, not phases, excuse me. Here were the traffic light that we looked at. So green was that we had less than 15% of the workforce called out. So this was normal status, normal day-to-day, standard operations. Proceed as normal. The next one was yellow. Yellow was you had one clinical support staff per clinician. Please understand, our model is normally 1.5 to each provider. So that's a clinical assistant, some people call it a medical assistant, and half a nurse. So one nurse to 2 providers. Everyone with me? Great. So then this was one clinical staff to 1 provider. So we know we need to start reducing. We don't have the same clinical presence. So here what we would do is automatically shift the patient visits to urgent care, right? They're problem-focused visits. We suspend PCMH expectations. The whole holistic care, someone mentioned that earlier, that we've kind of escaped from it. We consciously, we said we were going to separate ourselves from the holistic because we are in a crisis and we need to manage the situation at hand. So that's what we did. Then we also concentrated on vaccines, right? So the vaccines were only flu and pneumonia for adults. And of course, all childhood immunization continued. And then lastly, we only did essential point of care testing. So your lipids, your AC1s, your HIV, your pregnancy tests, those are the ones that we would do. Everything else we would send out, okay? That was yellow. So we would see this. I would know what center was doing what. I could see how many were yellow, how many were green. The red, which now you're coming into danger zone, right? So the red was that you actually had 2 providers only supported by 1 clinical assistant. So now you're really upside down. Now the provider's not getting all the support that's necessary. You have to pay even closer attention. You don't want any medical mistakes, etc. So in this case, we would reduce it even further. So here we go. Urgent care visits, right, which I've already explained. But now the vaccines change. The vaccines are still pneumonia and flu, but now for children is 18 months and younger. So now we've eliminated a whole slew of those well childs and kept them out of the health center intentionally because we don't want medical mistakes. We have to limit how many people are coming in because we don't have enough clinical staffing. Then the last phase, what I call the blackout phase, is the same thing as when we have a blackout in the city. Lights out, it meant we do not have enough staff to run the health center. That center needs to be closed, and on this spreadsheet, on this dashboard, we would see where are those patients going to be seen and where are those staff going to be redeployed to. And that's when we start shifting to a regional model. All right? So, what are some of the, in summary form, what are some of the practices we believe will repeat until we learn something more effective and better? Here are a couple of the items. Number one, I think I never mentioned to you that during the pandemic, we actually stood right on the front line of all of the tests, or all of the testing. As you can all remember, the Department of Health, and this is not a slight in any way, and the government really started to focus on the hospitals. All the testing kits were going over there, same way that all the vaccines were going over there. And for those of you who are FQHCs, this is a time where we pat ourselves on the back, because we've been saying this for how many years? So many of us have been in existence for 40 plus years. We're the ones that in the community. We know how to do this best. Plus, we were all trained by CHCANYS, so we can handle some pods. So what we did was we started doing pop-up testing. Some of you who may live in Long Island may have seen us in the news in Long Island and also in Westchester County. We did pop-up testing here in the city, but of course it was in the middle of the city and in some of the more blighted areas, East New York, so no media coverage there. So we are really proud to say that we actually did over 175,000 vaccines in New York State. But all of that was during the time that I just mentioned. All these staffing issues and keeping the health centers open, et cetera. So on separate form, parallel fashion, we were running all of these pods. And the way we were able to do that, and actually at times help in the health center, but mostly focusing on these pods and vaccination clinics, was the use of EMTs for vaccination pods, okay? I think the Department of Health, the feds, the state level, local level, and so many of our associations were so instrumental in linking us to great resources. So one of the greatest resources that we had were the EMTs. They wanted to help. They volunteered, and so they were perfect for vaccinating. The other thing we did was, again, partnering with the Department of Health. Department of Health had a tremendous list of volunteers that they were keeping, and we would be able to tap into that respective list of staff that were available and work hand in hand. It was literally quite a few times a week communication between us and the Department of Health in terms of staffing, and there wasn't a single event, particularly around vaccinations, that weren't staffed with some level of DOH volunteer or assisted volunteer, et cetera. The other thing that we also needed to focus in on, and I would really highly recommend, if you didn't have to do this, that you start figuring this out now in preparation for whatever comes in the future, is expedited onboarding for volunteers. Because at the end of the day, folks, we still have our liabilities. We still have an organization to run. And just because someone wants to volunteer doesn't just mean that they can just come right in and volunteer. We all have our processes to onboard someone. So we had to figure out the expediting process. One of the things that we were able to do was leverage the main employer's documentation as support and verification of the individual who was presenting as a volunteer. So that if their employer was willing to give up that HR package and send it over to us, we would act as if it was our own HR package and allow them on board, right? Which makes it really, really quick. The other thing that we needed to do was to actually deputize a number of our managers to be able to do orientations. As you can well imagine, an organization of our size, our HR department, there's a lot of protocol around there in terms of onboarding and how orientations take place and when they take place. But here, in order to do it much more quickly, we had to train some managers to do the full orientation on site so that if someone presented today as a volunteer, I got their package tomorrow, by the third day they could be on working. That's how quick it was turning around. And then I talked a bit about the use of temp staff, volunteers, temp agencies, and staff. We used a ton of them, especially around the nursing when we had our shortages. But as you can well imagine, the temp agencies also felt the pinch of their shortages as well and being pulled for hospitals and everywhere else. But we put ourselves in that line, and we would ask and we would get when we could. And then lastly, as I mentioned earlier, so I won't kind of go deep dive into it, is the reassignment of staff. Kind of talk to you about some examples of that already. Now, supply chain. I think this is really critical. I don't think it's going to come up that much in people's presentations, so let's just talk a little bit about it now. It's one thing to figure out where you get your supplies from, right? I think we all realize we have to diversify where we get our supplies from. We were really fortunate, feds, state, local. It was a lot of great partnerships, a lot of communication, and a lot of relationships building quickly and ensuring that we can respond. And then behind that came a tremendous amount of supplies, right? We saw that in local counties, like in Westchester County, where Westchester County DOH just continued to rely on us, said we really want to see a pod over here. We would do a pod over there, and they would supply the whole thing, right? So there was a lot of partnerships, and you got to keep that in mind while we're doing this. But what we also notice is you almost have to really figure out where you're keeping all those supplies. You know, we were actually getting trucks, 18-wheelers coming through with pallets coming off. We had the fortune, because we have the four mobile units, that we have fairly large garages to keep those mobile units. So we put it in one of those garages. I will tell you that being here in the city, there's not that much real estate available, so this concept of garage clearly comes from a man who now appreciates the fact that he's got Hudson Valley and Suffolk County, because I have some real estate there. So I have a garage in Fishkill, right? And that's where all those trucks and all those pallets, I moved out the mobile units, and you would walk in, you would just have rows of pallets, all organized. You got to work with your clinical team, all organized, dated, knowing when things are going to expire. That inventory system was insane. What I'm saying to you is you got to figure out quickly, where can you house, where can you receive, where can you house, and learning an inventory system that allows you to continue to respond to what's needed, because the last thing we can have is someone go out there and not be able to have all the PPE necessary, as we heard so many cases of. So yeah, we kept our 3-month supply, and that's the way we did it, and I really encourage everyone to kind of pay attention to that. And then just to kind of wrap things up here, ongoing training on PPE and the use of policy, that has evolved. Folks went from using PPE one way the first day to completely differently today, from the concept of Google's face shields, gowns, doffing, downing. One thing I did not mention earlier, and I think is really important, is that the way we were able to preserve PPE is that part of the separation is that if you were in a quote-unquote dirty area, and this is where it's really important to define these things, we would make sure you stood in that area. So there was never a time where you were going to come from over there and then need to come into PEDS. That would make no sense. But we know through discussions that people were doing that. So every single time they did that, what do you think would happen? You were eliminating, you were discarding that PPE. So you were wasting it. We cut that out right from the very beginning. You are stationed, you are strictly doing vaccinations. Vaccinations and or testing, all considered dirty. You still completely PPD'd up. You don't remove it until you take a break. When you remove it, you hang it over here, but you stay over there. That's what we would do. And that's really important. It sounds kind of funny, but you would be surprised how much waste we were able to kind of eliminate just by simply doing that.
Hi, everyone. My name is Pat Troy. I'm the Senior Vice President for Health.
I got it. That was the sign. So I would just leave you with this then. You heard about relationships matter. I think a lot of times we work in our spaces, and we really need to understand that when we work like this and we come together like this, networking, understanding who are the players and who are the resources, and even if you don't know someone, picking up the phone, making the call, making the connection. And remember that your connections are no longer local. They're local, they're state, they're federal. Utilize all of them. Because what we're finding in our discussions is that they want to work with us as well. But they're not going to know you exist unless you give that call. Because it's the squeaky wheel that gets the oil. You have to be the squeaky wheel to make sure that your PPE is coming in, getting that oil. Those resources are coming in, getting that oil. A couple of last minute things I was going to talk to you about, but of course, I wanted to talk to you a little bit about safety in terms of the physical environment, but you all probably have been doing so much, but it's amazing how we all understand now HVAC cycle times, right? How much airflow we got through a place, introducing air filtration units. what that does for us now as we're constructing new health centers and what we're paying attention to there. But lastly, communication. I told you about the nightly meeting. I told you about the morning meeting. I told you about the amount of meetings that we would have with all the local and regional and federal folks. But I think that the most important thing is that we are able to flex when we need to flex. We're able to adopt when we need to adopt, and we're able to adjust when we need to adjust. Last thing, utilize each other as a resource. It's great that we're having this meeting today. It's great that I can share this today. Would have been better that I could have shared everything we were learning as we're going just by a simple phone call. So thank you.